Welcome to the Deep Dive, where we take a stack of information and extract the most important nuggets to get you well-informed, fast. Today we're tackling a topic that is really foundational for anyone in healthcare, especially those of you on your nursing journey. Imagine a patient, maybe a 58-year-old woman, who comes in with unusual fatigue, some shortness of breath, and this, nagging ache in her upper back. Is it just stress? Indigestion, maybe? Or, is it something far more serious, silently progressing?
Indeed, that scenario perfectly illustrates why our deep dive today into coronary artery disease and acute coronary syndrome is so critical. We're drawing from Lewis's medical surgical nursing to give you a clear, structured understanding of these conditions. Our mission really is to cut through the density, offering you insights into the pathophysiology, the risk factors, clinical signs, diagnostic tests, and most importantly, the nursing management.
That's right. Think of this as your essential shortcut, not just for understanding these topics for exams like the NCLEX, but, for real-world clinical practice. We want you to walk away with those aha moments, confidently grasping complex medical terms and seeing exactly how the nursing process applies in acute care, chronic care, everywhere. After all, cardiovascular disease remains the leading cause of death worldwide, and coronary artery disease, or CAD, is its most common type. This is knowledge that quite literally saves lives. Okay, let's unpack this. We often hear heart disease, but what exactly is CAD, and why is it so prevalent?
Okay, CAD is fundamentally a disorder of your blood vessels, specifically the coronary arteries that feed your heart muscle. It falls under the umbrella of atherosclerosis. That term itself is quite descriptive. It comes from Greek words meaning gruel or fatty mush and hard. So picture the normally smooth, elastic lining of your arteries gradually becoming stiff and clogged, kind of like an old pipe rusting and narrowing inside. When these fatty deposits, called atheromas, build up specifically in the coronary arteries, that's CAD. And it's a progressive disease, meaning it develops over time.
So it's not a sudden event, but a slow, kind of insidious process then. How does this hardening actually happen?
Well, it begins with endothelial injury and inflammation, essentially damage to the inner lining of the artery.
Damage like from smoking or high blood pressure.
Exactly. Smoking, high blood pressure, high cholesterol, diabetes, even certain infections or toxins. Lots of things can injure that normally smooth lining. This damage triggers an inflammatory response. And then it unfolds in stages. First, you get these things called fatty streaks. They're just lipid-filled smooth muscle cells. What's striking is that these can show up in coronary arteries as early as age 20.
Wow, age 20, that's young.
It is. Then, next, fibrous plaque forms as collagen covers these fatty streaks, usually by age 30. This is when the artery starts to narrow, reducing blood flow.
Okay. And the worst stage?
That's the complicated lesion. Here, the plaque becomes unstable. It can potentially ulcerate or rupture. When that happens, platelets rush in, forming a thrombus, a blood clot, which can further narrow or even completely block the artery.
And that's often when the serious symptoms start.
That's often when a patient experiences acute symptoms, yes.
Okay, so here's something interesting I read about collateral circulation. Can the body actually create its own detours around these blockages?
Right.
Sounds like a built-in plan B.
It can, yeah, to a degree. And it's quite remarkable. Collateral circulation refers to arterial anastomoses, which are these sort of natural connections between arteries. These detours can grow in response to genetics or, crucially, chronic ischemia that's a prolonged lack of blood flow. So if a blockage develops slowly over years, the body has more time to develop these collateral vessels that can actually help maintain some blood and oxygen supply.
But not always enough, especially under stress.
Exactly.
Yeah.
Especially during increased cardiac workload. And critically, if an artery suddenly occludes, like with that ruptured plaque we mentioned, there's simply no time for these bypasses to form. That leads to immediate and severe consequences.
Okay, so if you're a nurse assessing a patient, what puts someone at risk for CAD? I know there are factors we can't change, and thankfully those we can influence. What's one non-modifiable risk factor that nurses maybe often overlook but has a huge impact on patient outcomes, and why?
That's a great question. We categorize them into non-modifiable and modifiable risks. For non-modifiable, you've got age risk increases for men over 45, women over 55, ethnicity, family history, genetics. But the one often overlooked with a huge impact is gender. Specifically for women, women are often diagnosed about 10 years later than men, and crucially, they often present with atypical symptoms.
Atypical how?
Things like fatigue, shortness of breath, maybe upper back pain or indigestion, not always that classic crushing chest pain you hear about. This can lead to delayed diagnosis and, unfortunately, a higher mortality rate after their first heart attack. So as a nurse, you need to be really attuned to these subtle presentations.
That's a really powerful reminder for us as clinicians. Okay, what about the major modifiable factors, the ones we can actually influence through nursing interventions?
Right, these are absolutely critical areas for us. High serum lipids are paramount. We're talking total cholesterol over 200, LDL, the bad cholesterol, over 130, low HDL, the good cholesterol.
The stuff that carries fat away.
It's exactly. HDL, less than 40 in men or 50 in women, is a risk. And high fasting triglycerides, over 150. Then there's hypertension, high blood pressure. It causes direct damage to the artery lining and makes the heart work harder, leading to left ventricular hypertrophy. Tobacco use is just incredibly damaging. Nicotine increases heart rate, blood pressure, constricts vessels.
And the carbon monoxide reduces oxygen.
Right, and injures the endothelium. The benefits of quitting are dramatic and pretty immediate. Remember to counsel against all tobacco products, including e-cigarettes and secondhand smoke exposure. Diabetes is another big one. It increases CAD risk 2 to 4 times, even when glucose is well controlled, and patients often develop CAD earlier.
Right.
Sometimes undiagnosed diabetes is actually discovered after an MI.
Really? Wow.
Yeah. Then we have metabolic syndrome, which is a whole cluster of risks, central obesity, hypertension, abnormal lipids, high fasting glucose, and of course, physical inactivity and obesity, the BMI over 30, or a large waist circumference. Obese individuals often have higher LDLs and triglycerides.
Okay, that's a lot of risk factors. So this brings us right to the core of nursing. How do we promote health and manage CAD, both preventatively and when a patient already has it?
Our role in health promotion is huge. We identify high-risk individuals through thorough health histories, asking about family history, any cardiovascular symptoms, lifestyle, psychosocial stuff. It's really essential to assess a patient's health literacy too, so we can tailor our teaching effectively.
Makes sense.
Then we promote lifestyle changes, things like maintaining a healthy weight, exercising regularly using the FITT formula, that's frequency, intensity, type, and time.
FITT, got it.
Right. And following nutrition therapy focused on lowering that LDL cholesterol. That means reducing saturated and trans fats, think red meat, egg yolks, whole milk products, and increasing complex carbs, fiber, and those heart-healthy omega-3s like in fatty fish. We help patients make smart food choices.
Like using liquid oils instead of solid fats.
Exactly. Choosing whole grains, limiting added sugars. Then there's lipid-lowering drug therapy. Statins are the most common. They inhibit cholesterol synthesis. As nurses, we must educate on potential side effects, like muscle pain with statins, and the absolute importance of adherence. Patients need to stick with it.
What about aspirin?
Good question. Low-dose aspirin, like 81 milligram, is used for secondary prevention in those with known CAD. But its role in primary prevention, for folks without existing CAD, is now kind of controversial due to bleeding risks, particularly in adults over 60. And for gerontologic considerations, remember, CAD is still the leading cause of death in older adults. Aggressive treatment for hypertension and high lipids is still effective. We just might need to adapt activity and diet recommendations slightly.
Okay, so we've covered the background and risks. Now, what happens when CAD starts to show symptoms, specifically in the form of chronic stable angina?
Right. Angina, or chest pain, is the classic clinical manifestation of myocardial ischemia. That's when the heart muscle's oxygen demand exceeds its supply. This typically happens when a coronary artery is narrowed by, say, 70% or more because of that atherosclerosis buildup.
And chronic stable means it's like predictable.
Exactly. It has a similar predictable pattern: onset, duration, intensity, often provoked by physical exertion, stress, maybe emotional upset, the pain itself. Patients might describe it as squeezing, heavy, tight, a suffocating sensation. It might radiate jaw, neck, shoulders, arms. Sometimes it feels like indigestion or pain between the shoulder blades. Crucially, it usually lasts only a few minutes, and importantly, it subsides with rest or sublingual nitroglycerin.
So as nurses, how do we assess that pain systematically?
We use the PQRST assessment. It's a great mnemonic. Precipitating events, what brought it on, quality, what does it feel like, region radiation, where is it, does it spread, severity on a 0-10 scale, and timing, when did it start, has it changed?
PQRST.
But, and this is critical, remember those atypical symptoms we mentioned earlier, especially in women and older adults. Dyspnea, nausea, mid-epigastric discomfort, fatigue. We call this an angina equivalent, recognizing this is vital nursing work to prevent delayed treatment. There's also silent ischemia, where patients have ischemia but no symptoms, often seen in diabetics due to neuropathy affecting the nerves.
Okay, so a patient comes in with chest pain, maybe stable, maybe not. What are the immediate goals? What's the nursing priority right then and there?
The immediate goals are clear. Decrease oxygen demand, increase oxygen supply, provide pain relief, and prevent progression to something worse, like ACS. For acute care interventions, if a patient has chest pain, our first steps are position them upright, apply supplemental oxygen aiming for saturation above 93%, assess vital signs, get a 12-lead ECG, and hook them up to continuous monitoring.
Get that ECG fast.
Absolutely. Prompt pain relief is paramount. Start with sublingual or maybe IV nitroglycerin. If that doesn't work, an IV opioid like morphine might be needed. We also get cardiac biomarkers drawn, listen to heart and breath sounds. And as nurses, it's vital to evaluate pain before and after every intervention to see if it's working.
Makes sense. And for long-term management and patient education once they're stable, what do we focus on teaching?
Patient teaching is absolutely essential for managing chronic stable angina. We reinforce risk factor modification. We help patients identify and avoid their specific triggers. Maybe it's temperature extremes, heavy meals, strong emotions. For drug therapy, nitrates are key. Short-acting ones, like sublingual tablets or spray, are for acute episodes.
That's the one they take under the tongue.
Right. Crucial teaching point. Take one dose, wait 5 minutes. If there's no relief, call 911 immediately. Don't drive yourself. Store it properly. Expect maybe tingling or headache. Long-acting nitrates are for prevention, but they require a nitrate-free period each day to prevent tolerance. ACE inhibitors, or ARBs, are often prescribed, especially if the patient has a reduced ejection fraction, meaning the heart isn't pumping as effectively, or if they have diabetes, hypertension, or kidney disease.
They help prevent that ventricular remodeling, right?
Exactly. They help prevent the heart muscle from changing shape in unhelpful ways after injury. Beta blockers are also standard. They reduce the heart's workload, lower heart rate, blood pressure. But teach patients never to stop them abruptly. Big risk of rebound problems.
Okay. What about diagnostic tests and maybe interventions beyond the initial ECG and meds?
Right. If the chest pain is new or changing, we definitely get that 12-lead ECG and cardiac biomarkers. But the gold standard to really visualize the coronary arteries is cardiac catheterization.
The heart cath.
Yep. And often, percutaneous coronary intervention, or PCI, is done at the same time if they find a blockage that's suitable. This usually involves balloon angioplasty to compress the plaque, followed by placing a stent, a small mesh tube, to keep the vessel propped open.
Those stents can be drug-eluting too, right? To prevent tissue growth.
Correct. Bare metal or drug-eluting stents. After PCI, DAPT dual antiplatelet therapy is absolutely crucial. That means aspirin plus another antiplatelet like clopidogrel or ticagrelor, usually for at least a year, to prevent the stent from clotting off.
That seems like a big adherence challenge for patients.
It really is. That's a major nursing-focused education about why it's so vital not to stop those meds. Now, for more severe disease, maybe multiple blockages or blockages not easily reached by PCI, coronary artery bypass graft, CABG surgery, might be the route. This involves using grafts, often veins from the leg or arteries from the chest or arm, to bypass the blocked coronary arteries entirely. Post-op nursing care is intensive, monitoring hemodynamics, watching for bleeding, managing fluids, electrolytes, pain, potential dysrhythmias. It's complex.
Okay, so chronic stable angina is predictable. But what happens when that chest pain is prolonged, not immediately reversible? When does it become a true code red emergency?
That's exactly when we enter the realm of acute coronary syndrome, ACS. ACS is an umbrella term that includes unstable angina, UA, non-ST segment elevation, myocardial infarction, NSTEMI, and ST segment elevation, myocardial infarction, STEMI. This is a critical emergency because, get this, heart muscle cells become hypoxic within just 10 seconds of a coronary artery occlusion.
Just seconds.
Yeah. And irreversible damage, actual cell death, starts after about 20 minutes if blood flow isn't restored. So time is quite literally muscle here.
Okay, can you break down those types of ACS? What are the key distinctions for a nurse standing at the bedside?
Absolutely. Let's start with unstable angina, UA. Think of this as chest pain that's either new in onset, occurs at rest, or is worsening, meaning it happens more frequently, lasts longer, or occurs with less effort than previous angina. It's unpredictable, lasts 10 minutes or more. On the ECG, you might see ST depression or T-wave inversion. But critically, the cardiac biomarkers, like troponin, are normal. No muscle death yet.
Okay, UA, unstable pain, normal biomarkers. What about MI?
Right. A myocardial infarction, MI, or heart attack, means there is irreversible myocardial cell death happening because of an abrupt stoppage of blood flow. We split MIs into two main types based on the ECG. A STEMI stands for ST segment elevation MI. This is typically caused by an occlusive thrombus, a complete blockage. The ECG shows that significant ST elevation. This is a top-tier emergency. The goal is reperfusion, getting that artery open, ideally within 90 minutes via PCI or within 30 minutes using thrombolytic therapy, those clot-busting drugs.
STEMI, ST elevation, blockage, open it, NW. Yeah, what's on stand-up bunny?
And STEMI is non-ST segment elevation MI. This is usually caused by a non-occlusive thrombus, a partial blockage. The ECG might show ST depression or T-wave inversion similar to UA, but importantly, no ST elevation. The key differentiator here is that the cardiac biomarkers are elevated. There is muscle damage occurring.
Okay, and STEMI, no ST elevation, but positive biomarkers. Still an MI.
Exactly. These patients don't usually need immediate catheterization like STEMI patients, but they typically get one within 12 to 72 hours to assess and treat. And very importantly, thrombolytic therapy is not an option for NSTEMI.
Okay, that's clear. Now, what are the classic signs and symptoms of an MI? We know the crushing pain, but beyond that, what are some other crucial things we might see as nurses?
Right. The most prominent symptom is often that severe, persistent pain crushing, heavy, maybe radiating, lasting 20 minutes or longer, not relieved by rest or nitro. But always remember those atypical symptoms, especially in women, diabetics who might have a silent MI with no pain, and older adults. They might just show confusion, shortness of breath, profound fatigue, nausea.
So we need a high index of suspicion.
Absolutely. Other vital signs. You might see sympathetic nervous system stimulation. The patient might be diaphoretic, sweaty, pale or ashen, clammy, cool skin with an initially high heart rate and blood pressure. Then, cardiovascular changes, BP might drop later. You might hear crackles in the lungs if the left ventricle is failing, or see JVD, jugular venous distension, if the right side is failing. New S3 or S4 heart sounds can indicate problems with ventricular filling or ejection. A new murmur could signal valve trouble. Nausea and vomiting are common too, either from the severe pain or vasovagal responses, and maybe a low-grade fever due to the inflammation from cell death. As the heart heals over weeks, scar tissue forms. It's less compliant, which can lead to ventricular remodeling the heart-changing shape. That's where those ACE inhibitors really help limit that negative remodeling.
That healing process sounds complex. What kind of complications do we need to watch out for after an MI? What keeps nurses on high alert in the CCU?
Oh, complications are frequent and can be really serious. Dysrhythmias are the most common, occurring in 80–90% of MI patients, especially life-threatening ones like ventricular tachycardia, VT, and ventricular fibrillation, VF, often in the crucial first few hours, even pre-hospital. Continuous ECG monitoring is non-negotiable.
So, eyes on the monitor, always.
Always. Other big ones, heart failure. When the pumping action is reduced, you'll see signs like dyspnea, crackles, maybe that S3 sound for left-sided failure, or JVD and edema for right-sided. Cardiogenic shock is severe pump failure, a really high mortality complication requiring aggressive management, maybe mechanical support devices. Then there are structural problems. Papillary muscle dysfunction or rupture can cause acute mitral valve regurgitation. You might hear a new loud systolic murmur. Or even more catastrophic, a ventricular septal wall rupture or left ventricular free wall rupture. These are surgical emergencies. Also, pericarditis, that inflammation of the sac around the heart, can happen a few days post-MI. Causes chest pain that gets worse when breathing in, often relieved by sitting forward. You might hear a friction rub. And Dressler syndrome, which is like a delayed pericarditis, maybe autoimmune, weeks later.
Okay, a lot can go wrong. With all these possibilities, how do we definitively diagnose ACS when a patient presents?
The primary diagnostic tools are the 12-lead ECG. And remember, serial ECGs are crucial because changes can evolve over time, and serum cardiac biomarkers.
ECG and blood tests.
Right. ECG findings like ST elevation for STEMI or ST depression wave inversion for UN STEMI give us critical initial clues. The specific leads showing changes can even tell us which part of the heart and likely which coronary artery is involved. Then the biomarkers. Troponins, specifically cardiac troponin T and I, are highly specific indicators of heart muscle damage. They typically rise 4–6 hours after the MI starts, peak around 10–24 hours, and stay elevated for days. Newer high-sensitivity troponins can rise even faster within an hour.
So troponin levels really distinguish MI from unstable angina.
Exactly. Elevated troponins confirm MI, either NSTEMI or STEMI. They are normal in unstable angina. We also might look at CKMB, another enzyme, but it's less specific than troponin. And finally, cardiac catheterization remains crucial, especially for STEMI patients. Goal within 90 minutes, and usually within 12–72 hours for UN STEMI to confirm the diagnosis, see the blockages, and guide treatment like PCI.
Okay, so the diagnosis is made. What are the key interprofessional and nursing interventions for ACS? What's the immediate to-do list in the ED or cath lab holding?
Immediate rapid treatment is absolutely paramount. It's all about restoring blood flow quickly. Upon presentation, the emergency management sequence is key. Vital signs, get that 12-lead ECG within 10 minutes, continuous ECG monitoring, position the patient upright, apply oxygen if needed, establish IV access, give sublingual nitroglycerin if BP allows, give chewable aspirin, morphine for persistent pain, often a high-dose statin right away, and draw baseline labs, including those biomarkers.
Kind of like that MONA mnemonic, but maybe expanded. Morphine, oxygen, nitro, aspirin, plus other things now.
Exactly. Mona is a classic starting point. But we also add antiplatelets, statins, maybe beta blockers early on. Now for reperfusion therapy, specifically for STEMI, emergent PCI is the preferred strategy if the hospital is capable. The goal is door-to-balloon time within 90 minutes to get that blocked artery open with angioplasty and usually a stent. Post-PCI, that DDAPT, aspirin plus ticagrelor or prasugrel, is critical, usually for a year.
And if PCI isn't available quickly?
Then thrombolytic therapy, those clot busters like alteplase or inectoplase comes into play. The goal is to administer it within 30 minutes of ED arrival. Nurses play a huge role here, rigorously screening for contraindications to prevent bleeding complications like recent surgery, stroke, bleeding disorders, administering the drug correctly, and then vigilantly monitoring for signs of reperfusion, like the ST segment returning to baseline, pain relief, and crucially, any signs of bleeding, especially intracranial hemorrhage.
Bleeding is the big risk with thrombolytics. Got it. What about other drug therapies used across the board in ACS?
Yeah, several others are standard. 5-D nitroglycerin can be used for ongoing chest pain, helping reduce preload and afterload. Morphine for pain not relieved by nitro. It also decreases cardiac workload and anxiety. Beta blockers are usually started within 24 hours to reduce myocardial oxygen demand and lower the risk of reinfarction and heart failure. ACE inhibitors, or ARBs, are also typically started within 24 hours if the patient is stable, especially with anterior MI or reduced EF to prevent that ventricular remodeling. Antidysrhythmics are used only for specific, life-threatening dysrhythmias. Lipid-lowering drugs, usually high-intensity statin, are essential. Sometimes aldosterone antagonists are added post-STEMI. And don't forget stool softeners.
The stool softeners, why?
To prevent straining during bowel movements. Straining causes the Valsalva maneuver, which can dangerously slow the heart rate or trigger dysrhythmias in these vulnerable patients. And nutrition therapy. Initially, maybe NPO, nothing by mouth, then advance slowly to a low-salt, low-saturated fat, low-cholesterol diet.
Okay, makes sense. As nurses, our assessment and ongoing care are so central to patient outcomes. Beyond the immediate crisis management, what's the holistic nursing management for ACS look like?
Absolutely. Nursing management for ACS is really comprehensive. Our ongoing assessment involves collecting both subjective data, listening to the patient's story, their history, symptoms, risk factors, and objective data monitoring vitals, cardiac and lung sounds, skin assessment, tracking ECG changes, and biomarker trends. Our planning focuses on immediate goals like pain relief, getting the right treatment, preserving heart muscle, and then longer-term goals like helping the patient cope effectively, getting them into rehabilitation, and reducing future risks.
It's a marathon, not just a sprint.
Exactly. In acute care, we're doing frequent vital sign monitoring, continuous ECG monitoring, maybe getting serial ECGs, tracking those serial cardiac biomarkers. We're managing pain, balancing rest with gradual, careful increases in activity. We're administering that crucial DAPT if they had a stent. And always, always vigilant for those life-threatening dysrhythmias and subtle signs of developing heart failure. Providing rest and comfort is key, planning care to minimize interruptions, and addressing anxiety and emotional responses is equally vital.
I imagine patients are terrified.
They absolutely are. Anger, fear, denial, depression, these are common. Nurses need to identify the source of anxiety, provide reassurance, explain things clearly, involve caregivers, and support healthy coping mechanisms. Patient teaching is ongoing and must be tailored to their health literacy. We explain what happened, the signs of angina or another MI, when to seek help, anatomy, risk factor reduction, the purpose of tests and meds, and set realistic recovery expectations.
What about activity after discharge?
We guide patients through a gradual, progressive resumption of physical activity, often using MEAT, metabolic equivalents, as a guide. We emphasize listening to your body and stopping if chest pain or shortness of breath occurs. We teach them the difference between isometric exercise, like heavy lifting, which can strain the heart, and isotonic exercise, like walking, cycling, which is beneficial. Cardiac rehabilitation programs are crucial for recovery, covering physiologic, psychologic, vocational aspects. We strongly encourage participation. It reinforces that CAD is a chronic disease needing lifelong management. And finally, we need to address often neglected areas like resuming sexual activity.
Yeah, that's probably awkward for patients to bring up.
It often is. We need to initiate the conversation. Counsel patients and partners that it's typically a moderate energy activity, generally safe when they can comfortably do activities requiring 3 to 5 METs like climbing 2 flights of stairs without symptoms. And a critical warning, never use erectile dysfunction drugs like sildenafil if they're also taking nitrates. That combination can cause life-threatening hypotension.
Wow, that's a vital piece of teaching. Okay, finally, let's touch on the most abrupt and devastating outcome. Sudden cardiac death, SCD.
Yeah, SCD is defined as an unexpected death, usually within 1 hour of symptom onset, due to a sudden disruption in heart function. The cause is most commonly a life-threatening dysrhythmia, like that ventricular tachycardia or fibrillation we talked about. What's truly sobering and scary is that in up to 50% of cases, SCD is the first manifestation of underlying coronary artery disease. The person didn't even know they had significant heart disease.
Half the time it's the first sign. That's terrifying.
It is. A major risk factor for SCD is having had a previous MI that caused significant damage, resulting in poor left ventricular function, specifically an ejection fraction, EF,
Yeah.
that measure of pumping ability, less than 30%.
So what's the care like for someone who survives an SCD event?
Survivors undergo an intensive diagnostic workup. We need to figure out why it happened. This includes ruling out an acute MI, doing cardiac catheterization to look for significant CAD, maybe electrophysiology studies, EPS, to assess their risk for further dysrhythmias. The most common approach to preventing another episode is the implantation of an implantable cardioverter defibrillator, ICD.
The device that shocks the heart back into rhythm?
Exactly. It constantly monitors the heart rhythm and delivers a shock if it detects VT or VF. Sometimes a wearable defibrillator vest is used temporarily, and it underscores the public health importance of early CPR and widespread access to AEDs, automated external defibrillators. They significantly improve survival rates for witnessed cardiac arrests.
It must be incredibly traumatic for survivors living with that possibility.
Oh, absolutely. They often develop what's called a time bomb mentality. Anxiety, anger, depression are very common. Nurses play such a vital role here in providing emotional support, education about living with an ICD, psychosocial adaptation, maybe driving restrictions, and reinforcing those necessary lifestyle changes.
Wow. That was a truly comprehensive deep dive into CAD and ACS. We've covered so much, from the microscopic changes in the arteries all the way to acute care, long-term rehab, all through that critical nursing lens.
We really have. We've seen how crucial early recognition is, how rapid intervention saves muscle, and how comprehensive patient education shapes long-term outcomes across the whole spectrum of these diseases. Understanding the why, the pathophysiology, helps you anticipate what you'll see clinically. And the nursing process provides that framework for your assessment, your interventions, your teaching, and makes you an invaluable part of the healthcare team.
So what does this all mean for you, the listener? As you continue your nursing studies, as you move into practice, just remember that every patient's story with CAD and ACS is unique. The key isn't just memorizing facts, right? It's understanding the interconnectedness of these systems and, importantly, the human experience within them.
Exactly. And maybe as a final thought to ponder, consider this. Given what we know about the high rates of atypical symptoms, especially in women and older adults, and how silently CAD can progress, how might future nursing assessments, maybe community health initiatives, evolve to better catch these conditions earlier, before they become those life-threatening ACS events? Just something to keep you thinking as you move forward.
That's a really powerful question to end on. Thank you so much for joining us on this deep dive. Stay curious, stay informed, and keep making a difference out there. We'll be back soon with another deep dive for you.